Are on live. Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the brand new episode of Optometry series. So, Anshi ma'am, we are in the very new format, and this is the second season. And we are in the episode one also. So, what is the idea or what is the format of the new season, and who's today's moderator, and what is today's topic, ma'am?
Hi, Gomati. I'm very happy that we have finished one season. We've completed 50 episodes. So, this is our 51st episode, but we would like to call it as Optometry Series 2.0. We are starting with the basics, where we're going to start with parts of the eye. So, let's go back, revive our anatomy and a little bit of physiology, and then move on to small basic diseases which commonly occur in that part, and then the common diseases which an optometrist can deal with. So, today we are starting with cornea. And we have Ms. Supraja, who's a very good an optometrist and is currently teaching. So thank you, Supraja, for saying yes for joining and being a moderator. So I would move on to the MC who would be introducing you, and then we can start the session.
Thank you, Anshita.
Good evening, one and all. I am Shatish, a first year Bachelor of Optometry student at Dr. Agarwal Institute of Optometry. It gives me immense pleasure to welcome our moderator for today, Ms. Supraja ma'am. Supraja ma'am is an optometrist, academician, and dedicated researcher. She is currently serving as an assistant professor at Avinashi Lingam Institute in Coimbatore and is driven by a deep passion for both academic and clinical practices. Her extensive professional journey includes training at the Sankara Nethralaya Eye Hospital in Chennai, and she brings with her over 12 years of experience in clinical practice, research, education, and community high health initiatives. She also has several publications and accolades to her credits. We are truly honored to have you with us today, ma'am. Thank you so much for joining us.
Thank you so much.
Now, okay, ma'am. Now, I would like to invite our presenter for the day, Miss Miraclin, a first year Bachelor of Optometry student at Dr. Agarwal's Institute of Optometry. Miraclin, please start your presentation.
Now I'm going to start with my presentation. My topic is about exploring corneal layers. Anatomical considerations. The cornea is a transparent avascular watch glass-like structure. It forms 1/6 of the outer fibrous coat of the eyeball. The word cornea has come from the word kerato, which in Greek means on or shield-like. Dimensions of cornea. In anterior surface, it is elliptical, diameter horizontal 11.75 mm, whereas vertical 11 mm. In posterior surface, it is circular, diameter 11.5 mm. Microcornea, when horizontal corneal diameter is less than 10 mm. Macrocornea, when horizontal corneal diameter is more than 13 mm. Radius of curvature. The anterior and posterior radii of curvature of the central part of cornea are 7.8 mm and 6.5 mm. Thickness. The central corneal thickness is 0.52 mm, whereas 0.6 mm thick. The central 5 mm of the cornea forms powerful refracting surface. Histology. Cornea contains 6 layers. From anterior to posterior, it is anterior epithelium, Bowman's membrane, stroma, predecimates membrane, decimates membrane, and endothelium. Anterior epithelium. It is stratified, squamous, and non-keratinized. There are 3 types of cells: superficial, wing cells, and basal cells. Basal cells. It is the deepest layer. It is a single layer cell. It comprises of columnar polygonal shaped cells. Wing cells. It is also known as umbrella cells. It is the middle layer of epithelium. It is anterior to basal and posterior to flat cells. Flattened cells. It has superficial 2 layers of corneal epithelium. It holds the tear film stability. Bowman's membrane. This layer has acellular mass of condensed collagen fibrils. It is 8 to 14 μm thickness. It is not a true elastic membrane but simply a condensed superficial part of the stroma. It is composed of randomly packed type 1 and type 5 collagen fibers. Unlike Decimet's membrane, once destroyed, it does not regenerate. Stroma. This layer is about 0.5 mm thickness and constitutes most of the cornea, 90% of total thickness. It consists of collagen fibrils, keratocytes, and extracellular matrix. Collagen lamellae is bounded with ground substance called proteoglycans. It maintains the shape and integrity. Pre-Decimet's membrane. Pre-Decimet's membrane, also known as Dua's layer, has been discovered by Dr. Harminder Dua in 2013. It is about 50 μm thick acellular structure. It is composed of collagen type 1, 4, 5, and 6. Proteoglycans are also present in this layer. This layer does not extend towards the periphery. The DAIO team with Dr. Arminder Dua at the IIRSI conference held at 2023 Decimet's membrane. It represents the basement membrane of corneal epithelium. It is made up of collagen and glycoproteins, which is visible on electron microscopy. Its thickness varies with age, being 3 μm at birth, 10 to 12 μm in young adults. It is the basement of endothelium, which is derived from endothelial cells. Acyl inlay bodies. The posterior surface of the Decimet's membrane at the periphery shows rounded wart-like excrescences. Similar central excrescences known as guttatae are seen with advancing age in Fuchs dystrophy. Endothelium consists of single layer of flat polygonal cells. The average thickness of endothelial layer is about 5 μm. Therefore, corneal decompensations occurs only after more than 75% of the adult age cells are lost. Endothelial cells are best evaluated by specular microscopy. Polymegatheism. Neighboring cells move over to fill the gap by sliding process and enlargement of cell occurs. Blood supply. Cornea is an avascular structure. Small loops derived from the anterior ciliary vessels invade its periphery for about 1 mm and provide nourishment. These loops are not in tissues. Have nerve supply. It is one of the richest nerve supply in the body. Supported by long, short ciliary nerve. Now we are biology.
Miraclin, just a minute, your voice is breaking. No, I can't hear anything. Just check your connection once.
Is it audible now, ma'am?
Yes, Miraclin.
Now we are moving on to corneal physiology. Transparency maintains. Collagen arrangement. Collagen fibrils in the stroma are uniformly spaced, reducing light scatter. There is no blood vessels. Corneal hydration, approximately 78%, maintained precisely. Too much water causes edema and loss of transparency. Endothelial pump function. The inner endothelial cells actively pump out water using sodium potassium ATPase and bicarbonate transporters. Corneal nutrition. It lacks blood supply. It relies on tear film, provides oxygen and glucose to the epithelium. Aqueous humor supplies nutrients like glucose to the endothelium and stroma. Limbal blood vessels provides nutrients to peripheral cornea. Oxygen supply. Primary source. Atmospheric oxygen via tear film, especially important when eyes are open. During sleep. Oxygen from aqueous humor, lower amount. Contact lens users may get hypoxia if lens doesn't allow oxygen permeability. Corneal metabolism. Glycolysis dominant. Glucose is metabolized to lactate. Lactate must be removed by endothelial pump. Buildup causes corneal edema.
Epithelium, eye metabolic activity important in wound healing. Endothelium, eye mitochondria density, active ion pumping. Wound healing mechanism. Epithelium heals rapidly within 24 to 48 hours for minor injuries. Basal cells divide and migrate. In stroma, slower healing may result in ACE or scarring due to fibroblast activity. Barrier functions. Epithelium tight junctions between cells prevent pathogen or microbe entry. Mechanical protection from external environment. Endothelium acts as a barrier and a pump, prevents fluid entry from aqueous into stroma. Intraocular pressure resistance. Cornea withstand internal eye pressure. Tonometry readings also depends on corneal thickness and biomechanical properties. Thinner corneas may underestimate IOP. Now we are moving on to corneal diseases. Keratitis, inflammation of cornea that can either be infectious, microbial, or non-infectious. Corneal dystrophy, a group of genetic disorders that involves abnormal deposits of proteins, fluids, or other materials in one or more layers of cornea. Fuchs dystrophy is most common type of corneal dystrophy. Bullous keratopathy, swelling and blisters on cornea surface. This condition may develop after eye surgery or because of corneal dystrophy. Corneal aberrations, an open wound on the surface of the cornea. It most commonly occurs after trauma, such as a fingernail scratch. Corneal ectasia, keratoconus, a group of condition that changes the shape of your cornea, causing it to thin and bulge outward. Keratoconus is the most common condition within this group. Keratoconjunctivitis, inflammation of both cornea and conjunctiva, the thin tissue that covers the white part of eye and lines inner eyelids. Pterygium, a growth on the white part of your eye that can extend to your cornea and rarely cause scarring. Iridocorneal endothelial syndrome (ICE), a rare condition that causes corneal swelling and increased pressure in eye. Here are my references. Thank you.
Thank you so much, Miraclin.
Thank you, ma'am.
Being a first year student, it was a great job. Can you mute yourself? Yeah. Thank you. And now I would request a moderator to add your inputs on the presentation, ma'am.
Is there a technical glitch? I'm not able to hear clearly.
Ma'am, is my voice audible? I guess there is a slight network issue from your side, ma'am.
My side? Am I audible now?
Yeah, ma'am. It's audible
Oh,
now.
okay. Yeah, I was not hearing voices only for some time. Okay. Can you repeat the question? The last 1 minute was not clear for me also.
Actually, she completed a presentation, ma'am.
Yeah.
Yeah, we
I
just
was there.
requested to add your inputs on the same presentation, ma'am.
Okay, so Miraclin is a first year student, right?
Yes,
Okay,
ma'am.
nice. Nice that she had covered diseases also. Physiology, it was good. Good job, Miraclin. Okay, just my points I just want to cover with regard to the optical properties. Some optical properties was missed, I think. Optically, cornea contributes, cornea is a refractive surface and the lens is also the refractive component of the eye. And majorly 74% of the refractive power is contributed from your cornea. And we know the refractive index is 1.3276. And if we combine both anterior and posterior cornea, the refractive index has mild change. Okay, and the refractive index also depends on the arrangement of the fibers. Stromal layer has multiple arrangement of there is a
lattice arrangement of fibers. So if the arrangement is not proper, it will lead to change in the refractive index. We know there is something called GAG, glycosaminoglycans. They also help in playing a major role in maintaining the refractive index of cornea. So only and the epithelium layer and the endothelium layer both has an important role. Epithelium layer is directly close to the environment, and it has this small projections called microvilli, which you showed in the presentation. The microvilli is very important in attachment of tear film. So the tear film stability mucin layer is directly attaching with the microvilli of the epithelium. That's why the stability is good. And also in the epithelium, we have below the epithelium, you have a small basement membrane. So it has been continuously secreted from the epithelium only, and that maintains that stability of epithelium and helps in adhering with the stromal layer. Then we have stroma. Stroma is the major component, and it is also responsible for maintaining the hydration in the cornea. So there is something called the swelling pressure. Okay, we have to know some physiology, right? Swelling pressure inside the stroma, cornea primarily. The swelling pressure is nothing but because of the presence of glycosaminoglycan, they have a small negative charge. So this negative charge makes the glycosaminoglycan molecules to repel each other. Since they are repelling each other, it creates a small pressure, which is called the swelling pressure. And cornea is a hydrated structure, but actually, if you see, look into it physiologically, they are having certain theories where cornea is actually less in wants to be dehydrated, but only then it is maintaining the hydration of the cornea. So there is a limit in the amount of water or the hydration entering the cornea. So the nutrition supply is from the aqueous, but aqueous cannot easily enter stromal layer because we have the tight junctions from the endothelium. So, and the endothelium and the epithelium both help in maintaining the rigidity, the not allowing the either the tear film to enter or the aqueous from entering the cornea. So, anything else you want me to add? And endothelium, primarily endothelium is a single layer, and we know it doesn't degenerate if the endothelial cells are lost. The whichever cell is lost, the space will be occupied by the nearby cells, and there will be a change in the endothelium. It will become the volume will increase, and there will be polymagatism. So that will be a sign of loss of endothelial cells. And we know that IOP is interrelated with the thickness of cornea. Normal thickness is 0.52 mm, but if it is increasing, if the thickness of cornea is more, it will lead to a false increase in the IOP. So we have to calculate the true IOP with having the central thickness, measuring the central thickness, and then only we will be getting the true IOP value. Okay. So I just want to add these few points. I want you to add anything more?
Thank you so much, ma'am. It had added many valuable inputs for the current presentation. And from the student's perspective, saying corneal diseases, we have it from inflammatory condition to degeneration, dystrophy, atretic conditions, and many more. And as an optom, we don't treat the corneal diseases as such. So, what would you advise for the optometry students to keep in mind before referring or doing any primary first aid for the corneal diseases, ma'am?
We don't do any first aid for corneal diseases. We, as optometry students, we should know how to diagnose the corneal diseases. So majorly slit lamp examination and fluorescence. Using the use of fluorescence, the dye, and examining the cornea with under the blue light, we'll get to know about the location of erosions, epithelial erosion. So it will also lead to identification of any presence of dry eyes or keratoconjunctivitis. And in cases of many inflammation, corneal inflammations like PEKs, punctate epithelial keratitis, it is a sign of other viral keratitis. So there we need to know after we put a fluorescent in under the blue light, there will be erosions, presence of these erosions. So there will be these epithelial staining. So that we need to know. While using the slit lamp, uh, looking at the optic section. In the optic section, we will have to look for the thickness. If there is any change in the thickness right from the periphery to the central cornea, we have to look at the length until the whole length of the optic section. We need to examine and look for any thinning. So in cases like keratoconus, there will be thinning in the cornea. So that we'll be able to identify. Then I just noted down something. So under the optic section, your slit lamp examination, there is something called sclerotic scatter. We will be able to identify if there is any refractive region where there is any refractive opacities in the cornea. We'll be able to identify sclerotic scatter. And another is specular reflection. So the principle of specular reflection is used in specular microscopy, and thereby we will be able to look at the endothelial cells. So these two we need to know, and under higher magnifications, we can also view the endothelial cells. Um, in slit lamp, it will be better if we optometry students know about the layers. If we look at the layers in a higher magnification, like above 40x, the layers will be visible. We can understand how the layers are, and in cases of abnormalities, after reference to a normal cornea, only if we see a number of normal corneal sections, then we'll be able to identify the abnormalities. So staining is also important. We'll be able to easily identify the epithelial defects.
Thank you so much, ma'am. Yeah. Am I audible, ma'am?
Yeah. You are audible.
Again, from the student's perspective, if there is any conditions like corneal aberrations or anything which is causing pain, redness in the eye for the patient, how should they proceed with the testings or parameters, and when do they have to refer to an ophthalmologist?
See, there is something called laceration, which is an extreme condition where the cornea is completely torn and there is aqueous draining in the anterior, even in the front of cornea. So when you put a fluorescent and the fluorescent is like leaking, you'll be able to easily look at in the slit lamp. If the fluorescent, there is water draining from, the aqueous is draining from the cornea, it is a real emergency. You need to check with the ophthalmologist and have a discussion. Then in cases of chemical injuries, it is very vital that we take it as an emergency and document if it is an alkaline injury or an acidic injury, because the defect is going to be different. In alkaline, it's going to be a much more defect. The however fast we act, we can regain some part of the cornea can be reduced from damage. So acidic, more than acidic, the alkaline injuries need to be addressed very faster. In cases of infections and presence of other erosions, we need to, if they are using contact lenses, we need to advise accordingly to either discontinue the lenses for some time and then refer if there are any, if the erosions are more, and if their staining is more, we need to refer them to the consultant so that it is managed well.
Thank you so much, ma'am. The last question is, what is the importance of color coding in documenting corneal diseases, ma'am?
Color coding is vital because uh, there is difference in the color coding for we know even the superficial vascularization, deep vascularization, there is a difference. So vascularization color coding is also done separately. So whether the vascularization is much deeper or just superficial in cases of certain contact lens induced emergencies. So we need to document it very well so that it is managed accordingly. In cases of opacity, there is a different coding. And in cases of minor erosions, it is different. So the color coding is vital in documentation.
Thank you so much, ma'am. These are the questions from the students. And over to Gomati now. Thank you.
Yes, thank you so much, Meenakshi. That was a wonderful set of questions and good presentation, Miracle. Best wishes. And Supraja ma'am, so thank you so much for joining us today as a moderator. It was great having you here, ma'am. Thank you so much.
Thank you. Thank you.
Yes, ma'am. Our students are actually on their study vacation. Study
Okay.
holidays are actually there, and some of
Okay.
the
Nice
students are
they have
already
joined
yes, ma'am. And some of the students are already having their practical exams. It is also going taking place
on
simultaneously.
simultaneously. Okay.
So after the exams are getting over, we'll be sharing the link with them. It will be a wonderful help for them to get back to the basics. So thank you so much, ma'am.
Thank
So
you.
dear audiences, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share the video with all your friends. With this, we're coming to the end of the session. Meet you all in the next episode. Thank you, Meenakshi.
Thank you, ma'am.
Thank you. Thank you. Thank you for inviting me. Thank you, Abishekina ma'am, for inviting me again. And I had an opportunity to interact with Agarwal for the first time. I personally know Janima ma'am and we used to interact, but this is the first forum where I'm interacting with the students and faculty. Thank you. Thank you for inviting.
We are also very happy to have you with us, ma'am. We are also expecting you to be hosted in other programs.
Sure. Thank you. Thank you.
Thank you so much, ma'am.
Thank you.